We'll move on to our next speaker now, Dr. Harshul Tuck. It's an absolute honor and privilege to introduce him. In short, if I had to say, I would say just what an amazing human being he is. But it's customary to introduce the scientific introduction. So Dr. Harshul Tuck is an admirable, innovative surgeon. He's a senior consultant from Marudhar Hospital, Jotwara, Jaipur. And he is my co-member, Academic and Research Committee, AIOS, from Central Zone. And we'll be looking at his pearl tip today. A very warm welcome to you, Dr. Harshul Tuck.
Thank you so much, Dr. Satyajit, for kind introduction. It's a great honor to be on ARC panel. So I'll be sharing a case of a mature cataract which had a fibrotic anterior capsule. Can you see my screen, ma'am?
Yes, yes.
Yes, we can see.
Okay. So this was a 70-year-old male patient who had, as you can see, a brown-black cataract and very fibrotic anterior capsule. So this case is being done under topical anesthesia. So after creating a side put incision and putting intracameral lignocaine, I stained the anterior capsule with Japan blue. And you see it was very difficult to initiate the capsular axis. And this entire mid-peripheral area was fibrotic. So I start making a small capsular axis with the capsular axis forceps. Now, why I wanted to make a small capsular axis in the first place was I wanted to check in which areas the fibrosis, it's fibrotic. So I see that it's fibrotic in almost all the places apart except from side port, between area of side port to the main port, because I may need to do some freehand capsular axis in that area because you can't put scissors there. So remember that these fibrotic anterior capsule, you need to cut with the micro scissors. So I go ahead and give a snip with the micro scissors, again put OVD. And from the side port, I, with the micro capsular axis forceps, I give a counter traction and hold this capsular axis edge, lift it up, and from another side port, I cut this fibrotic area. So I move on till I can cut from this side port. Now it's difficult to cut from this side port. So I make another paracentesis on the nasal side as I need to put the scissors in the right direction. And now in this area, there was a less of fibrosis. So I cut it till I can cut from this. Now with the dialer, I try to free up this subcapsular area from the bands because I need to do now freehand the capsular axis in this area. So once I free from this, I see the direction of the tear. It's always toward the center. Flatten the capsule, hold it and pull it towards the center. And you can see the tear going in the right direction because in this area, there is no fibrosis. So again, I change my hands, give counter traction with micro capsular axis forceps, use the micro scissors, and I get a capsular axis, which is of adequate size to take out this brown nucleus. Now, the vertical or horizontal chopping technique is always better in these kind of cases as zonules are also weak here. So this is the technique what I described as drill and chop. I drill in the center to weaken the central endonuclear core. And once I drill in the center, then I go ahead and hold this piece nicely in the deeper plane and chop it with a sharp this chopper. And you can see I splitted it in anterior posterior direction completely. And once I get these multiple pieces, I take them out one by one. So this is the last nuclear piece which is being taken out, and it we have the capsular bag, which is empty now. So as zonules are always weak, so always maintain the antechamber before you come out. And we should be careful while doing irrigation aspiration that we don't pull on the fibrotic area or the so that zonules don't come. I do some polishing beneath the anterior capsule. And this is the hydroimplantation technique. Put the irrigation cannula in the anterior chamber, and the IOL is implanted in the capsular bag. And hydro stitch is done, and this completes the case. So I think if you are careful enough, you can easily handle these kind of difficult cases, even under topical anesthesia, without creating any complications.
Harshul,
thank you very much.
Harshul, amazing case, amazing. You did a wonderful surgery. What an amazing surgeon you are. My primary question is, you saw so much of this capsule thing, and then it was a grade 5 cataract. Never thought of SICS?
No.
Why was it so important that you had to do phaco in this case? Or for the general ophthalmologist, for everybody, I want to know that would you want to suggest SICS, or you would suggest phaco?
I think it depends from surgeon to surgeon. Like whatever you are comfortable with, I think you should go ahead with that. If you are not comfortable with topical, I think even many would like to put peribulbar block in these kind of cases. So I think it depends on your level of comfort. So, but what I feel is that if you look at long term, if you use like Viscoat and all the newer machines, the results of phaco are, of course, far more better than the small incision cataract surgery.
Sure. Yes.
Yeah.
That was a very wonderful surgery, Harshul. Again, a case where you did it very well and made it appear a lot more easier than how it actually is. But just for the sake of discussion, if these were fibrotic calcified cataracts, I think those are the places where you would think of using a vitrector to get an opening and then go on to create the rexus.
Ma'am, if I'm not able to initiate the capsular axis with cystitome or with MVR blade or something, then next step what I use is the radio frequency dithermy probe. In Artley phaco machine, we have the radio frequency probes which easily cuts through fibrotic capsule. So in those difficult fibrotic, like this fibrosis was in the mid periphery where the capsular axis edge was there. If it would have been in the center or somewhere like I was not able to initiate, I use that. And if not that, then only I go to use the vitrector.
Anybody?
There was a ring of fibrotic,
yes,
ring of fibrotic ring. I mean, I would be tempted to, after putting the IOL, of course, remove that also, because that's the only thing which was a little pacified. And just to answer Satyajit's question, I think it is very important. Like for me to do SICS is difficult, and so I would go in for phaco. So I think it depends on what you are comfortable with. True, especially in this case, because there's so much of dense adhesion between the fibrotic capsule and the underlying nucleus. It remains to be seen that if you had actually done a rexus and tried to deliver, and if there were some other areas of similar adherence which are not visible to you, then SICS may have become difficult in such cases. Although I have no experience, so I don't think I'm the proper person, but that is what I would think.
I want to hear from you what you would have done in this case and the previous one where you were asking me whether I would do phaco or SICS. What's your thought like on this case and the previous one? Would you have done phaco or SICS?
Whom are you asking?
Whom are you asking?
I'm asking Satyajit because he's been pestering us with the SICS versus phaco.
I've been coming around too much with SICS.
Both the cases, what would
you tell me your question again?
On both the cases like this one and the previous one where the post-vitrectomy or post-injection where you were talking about this thing, or even the posterior polar one.
I would definitely go with phacoemulsification. These are routine cases. We do phacoemulsification every day in these cases. But because they are catering to a large ophthalmologist around the message to be going around, so that everybody who doesn't see a capsular tag like this and a grade 5 cataract says, I have to do phaco in this. That should not be the take-home message. Like Harshul said, you have to take your own call and decide if you are comfortable doing phaco, good, but you should also keep SICS in mind. For all these cases, we are regularly doing phacoemulsification, but I want it to be the message to go for everybody's benefit.
You're absolutely right.
I think when you're faced with a difficult situation, you should do what you're most comfortable with.
Correct.
As if you're regularly doing SICS, and when you see a grade 5 cataract, you do a phaco or the other way around. So obviously, most of the panelists here are more proficient phaco surgeons, so maybe this is the answer you will get. But obviously, there is a forum where people would do SICS and get equally excellent results. These are just depends on the surgeon entirely. Harshul, for you, the kind of fibrosis that was there, is it a traumatic cataract? Or it's
No. It was not a traumatic cataract. Yeah.
I really loved the way you completed the Rexes, making the side port incisions, having access, and the absolute fantastic control that you had. But apart from the beautiful video that you saw now, I'd also refer the audience to a couple of videos posted by Dr. Deepak Megor in the YouTube. He talks about the anterior capsular fibrosis, just like we talked about the posterior capsular fibrosis being different. There can be plaques under the anterior capsule, which can be separated and teased out, in which case the making of the capsular axis becomes fairly routine. The other situation where the capsule itself is fibrosed, in which case you might even have to use a vitrector to create an opening to access the nucleus. And these are concepts which you understand only when you see that video. But I found it very educative, so I just trying to add that point. But otherwise, wonderfully managed. And the other point is that as far as the brown nuclear cataracts are concerned, especially in traumatic cataracts, of course, you said your patient was 70-year-old, but some young patients, I find that the cataract is absolutely brown, but then it's soft also. It's almost, I call them the chocolate cataracts, where you expect a hard nucleus, but you end up, even though the color is brown, the nucleus comes out quite easily. And they're eminently choppable, or they almost come out like soft cataracts.
Gaurav, the theme of this session is top pearls in cataract surgery, not top pearls in phaco surgery.
But just one last point I want to add, ma'am, that one should never try to pull the fibrotic plaque, because that may cause the rexis to rip off uncontrollably towards the equator. So you should always cut through fibrotic plaque, and wherever you see the clear area, there you can try to pull it. Yeah.
Thank you very much, Harshul. Great video.